Welcome back to Platinum Unplugged. I'm Dr. Emily Abear, and this is Dr. Michael Chapman.
Hello.
I'm going to talk to you about a few things today. First off, Dr. Chapman is going to chat with us a bit about the new information on the monoclonal antibodies in COVID.
Sure. So there has been a lot of development, particularly this last week. Eli Lilly's monoclonal antibody has finished its first clinical trial. Although it was a small study, these are outpatients that were treated with the monoclonal antibody that had mild to moderate symptoms. And those that were treated, only 1.7% were hospitalized, as compared to 6% of people that were not treated or were given placebo. And so they're in discussion right now with the FDA as to whether or not to proceed with further clinical trials or apply for emergency use authorization. So this is kind of moving along pretty well.
Yeah, it's exciting. Definitely. Yeah. Well, thank you for that information, Michael. A couple new things this week as well. Actually, not this week, but in the last couple of weeks. First, the CDC has adjusted their testing guidelines. At this point, they would like to have even people that are asymptomatic and possibly have for sure been exposed to COVID. They'd like asymptomatic potential COVID carriers to be tested now. In the past, they said if you've been exposed, quarantine at home, especially if that exposure met the criteria that the CDC has outlined in terms of what's considered a close contact. So within 2 days prior to their a person's positive test or symptoms, and within that 6 feet distance that we talk about a lot. Now, the recommendation is test these folks if they have a significant exposure, even if they're asymptomatic, because again, the chance for asymptomatic spread and pre-symptomatic spread of COVID is now, they're thinking upwards of 40% in the community. So that's, that ends up being really, really important in terms of identifying people who truly have COVID. So that was a big one.
Yeah. And what would be the timing of testing? Because we don't want to test too early.
Of course, yeah, great question. Because as soon as people get exposed, the instinct is, I got to go get tested, make sure I don't have it. 5 to 7 days, ideally even closer to the 7-day mark, we're more likely to catch high enough viral replication and viral particles so that we will more likely have a positive test if you truly have, if you've contracted the virus, even if you're asymptomatic. So at least 5 days, and ideally even out to 7 days if possible. So good question.
Yeah. And to quarantine during that time.
Absolutely.
If you've had a good story of exposure.
Quarantine is extremely important. Again, if you live in a home where it's difficult to quarantine from your family, you've got to wear a mask and you've got to try to stay away from them as best you can. So yeah, of course, quarantine. Mm-hmm. The second kind of big piece of news, I guess, sort of, this week was that the CDC had published on their website that they felt that COVID was aerosolized, which has been a back and forth between the CDC and the WHO since mid-March. They quickly retracted that statement, and when you read the CDC website, it's clear as mud. Mm-hmm. And what they say is that they had erroneously posted the statement about the fact that COVID is aerosolized and passage of COVID, it happens through aerosolization of the virus. Now what they're saying is they're getting their language correct to release a statement at some point here down the road. So what does that mean? Well, I think for us, what I'm recommending to patients is until somebody can tell me for sure that it's not aerosolized, it's aerosolized. It would be great if it isn't, because that makes it a lot easier to contain in terms of spread. But until we really hear something definitive from the CDC, I'm going to say it's aerosolized until proven otherwise. That's my approach. I'm not sure about you.
It sounds reasonable. The number of people that have gotten sick.
Exactly.
It must be.
Yeah. I mean, again, it's why do some people get it that are in a room with John Doe and other people don't? There's got to be some underlying explanation that I'm not smart enough to know quite yet. We're fortunate today because we get to hear some from Dr. Nina Radford about all of the cardiology updates in the post-COVID world. So I'm going to send it to Dr. Radford.
Thank you so much. I'm so happy to be on the program to give you my perspectives as a cardiologist about the kinds of clinical questions raised during the current COVID-19 pandemic. One of the biggest questions that I get is what is the impact of having a COVID infection in the past have on returning to regular physical activity? For most people who may exercise 30 minutes 5 days a week, light intensity, moderate intensity, the impact of having a mild or an asymptomatic COVID infection really is very little to none. If you're feeling well, most people will recommend give yourself 2 weeks of convalescence after your symptoms resolve. Start back with low intensity and build yourself up as you're able to, because no matter what causes us to have some downtime from exercise, it's easy to get deconditioned and it takes a little while to build yourself back up. For those of us who have teenage children, young adult children, or even for those of you who may be much more highly competitive, there is some concern that moderate symptoms, prolonged illness with fever, could increase the risk of things like myocarditis. If you're in a situation, or again, an adult child, teen child is in a situation where they are highly competitive athletes, they've had a significant COVID infection, I encourage you to talk with your doctor about whether or not you need additional testing with an EKG, an echo, or even a cardiac MRI. This is a fairly fluid area of knowledge as additional testing is coming in about what are the best ways to identify those people who might have inflammation of the heart after a significant COVID infection and who are at risk for sudden death. So again, if it's something that you're concerned about at a level of pretty high intensity activity, I think it's a good thing to discuss with your physician before you go back to exercise. The other question I get frequently right now, which is in the news, is whether or not the use of an ACE inhibitor or an ARB type medication, and these are most commonly given to treat high blood pressure, puts you at risk for either getting COVID disease or having more severe COVID disease. So where this all has sort of come up is the fact that the COVID, the SARS-CoV-2 virus, the way it gets into the body is through the ACE2 peptidase, which is on the surface of a cell. And that ACE2 peptidase is part of a very complicated biochemical set of reactions where you have ACE inhibitors and ARBs involved and bradykinins, and it is alphabet soup full of enzymes and reactions. And the fact that this ACE2 inhibitor is involved has raised the question, if we have an ACE inhibitor drug or an ARB drug that works in that whole gamish of biochemical reactions, will they increase your risk of getting COVID or dying or getting very sick from COVID? And this has been a huge area of debate. In many societies, they're putting out expert recommendations week to week, month to month, in terms of where we stand on this. The current recommendations, based on some studies that have been published, based on some basic science work that we know about, is if you're on these medications for specific indications like kidney disease, heart disease, prior heart attack, you ought to continue taking these medications. And in fact, at a recent European cardiology meeting, they actually presented the results of a randomized trial where they took half of the people off these medications when they were in the hospital very sick with COVID, and half the people they kept on them. And they really did not see that if you took people off these drugs, they did better. And so that was the first randomized trial that showed this. So if you're on an ACE or an ARB and you have those compelling indications, if you're treated for hypertension and you're doing well, you ought to stay on those medications. Where there's a little bit of gray is if you have high blood pressure, but you're otherwise totally healthy, but you might be at risk for getting COVID because you are elderly, because you have emphysema, for example. The question is, if we're going to start you on something, should we start you on an ACE or an ARB, or should we consider a different medication? And at this point, there are some experts who are suggesting use a different medication. We have different drug families, calcium channel blockers, beta blockers, diuretics, and maybe consider one of those drugs until we have further data. But if you're taking the drug now and you're doing well, there is no indication to stop the drug in order to prevent a COVID illness or to keep that COVID illness from becoming quite severe. Again, if you have questions about this, rather than just stop your medications, I really encourage you to reach out to your doctor and ask them, in your particular case, are you well served staying on these meds? And I suspect that in 99% of the cases, the answer will be yes, you should continue.
Thank you, Dr. Radford. That's some really good information that we got on some cardiology aspects.
Yes, helpful.
So as we wrap up today, I just want to remind y'all just on the vitamin D that we've talked about before. You know, since our last video, there have actually been more and more studies come out reaffirming that optimal levels of vitamin D do reduce the severity of COVID symptoms should you become sick, and also can add protection of not getting the virus. So, you know, please, like we said before, check your vitamin D levels. Make sure, we'd love to see vitamin Ds in the 40s and above. And actually, vitamin D is now being used in the hospital upon ICU admission as a prediction of outcome. Those with good vitamin D levels have much better outcomes in the hospital setting. So
it's a win-win.
Yes. And then lastly, just stay tuned. You'll be receiving an email from Platinum on flu clinics. We have 4 dates set up here in late September, early October, so come in and get your flu shot.
Yep, that's exactly right. We've got to get those flu shots. So thanks so much for watching, and we will see you next time.